I'd like to acknowledge that we are on Treaty 6 territory in the homeland of the Métis. The learning objectives are listed here, and what we're going to have is 3 presentations. I will speak first, then Dr. Mark Anton will speak second, and Dr. Tu will speak third, and we will leave an opportunity for some questions and answers afterwards. And so I would like to get started so we have so we finish on time and have time for discussion. So I will be summarizing in some 20-odd minutes 38 years of phenomenal progress in biomedical advances in the field of HIV/AIDS. Here are my conflicts of interest. I do a lot of clinical trials of antiviral drugs. So I'm summarizing 38 years of HIV history on one slide, which I thought is somewhat ambitious. And of course, I know that many people in this audience are under the age of 38, which is interesting. That means you've never lived in a world that didn't know about HIV/AIDS, which is kind of interesting. So in 1981, in June in particular, the U.S. Centers for Disease Control reported to the world the occurrence of Kaposi's sarcoma and pneumocystis pneumonia in gay men in the United States. And this was completely unexpected because these were individuals who were not known to be immunodeficient. And within a few months of that, they also reported similar cases in injection drug users and people with hemophilia. So by the next year, 1982, the CDC coined the term AIDS, and the scientific search began around the world for the cause. And in the latter part of 1983, the laboratory at the Pasteur Institute, led by Luc Montagnier, was the first to isolate the virus we today understand to be HIV-1. It was independently isolated by Robert Gallo in Bethesda at the NIH, and then third by Jay Levy at University of San Francisco, UCSF. And by 1984, it was accepted by the scientific community that HIV was indeed the cause of AIDS. By 1985, we had a blood test that was widely available, at least in high-income countries, and we were able to secure the safety of the blood bank by screening blood products and tissue donors for HIV. And then in the fall of 1986, we saw Margaret Fishel present at an ICAC meeting in New Orleans the data of AZT, being the first antiviral to show some efficacy in HIV, showing a survival benefit, but unfortunately only a modest survival benefit. But it opened the field to drug discovery, and we understood that at least a reverse transcriptase was a valid target for antiviral drug development. We have to go forward 10 years till 1996, when we first saw suppressive antiviral therapy with combinations of antiviral drugs. Suppressive meaning that for the first time we were able to suppress the viral load to below the limit of detection in a majority of people living with HIV. And that was done, as I said, in 1996. And then laboratories had to introduce viral load testing for the first time because we had a reason to do that. And it took another decade of therapy before the first single tablet regimen came to be. So in the early days, there were multiple tablets taken multiple times a day with lots of drug interactions and food restrictions. But by 2006, we had a first single tablet regimen. And then toward the end of 2010, we saw the publication of the IPREX study, which was the first study to show that antiretroviral therapy could prevent HIV infection in people who were HIV negative. And we went back and forth in the field, not understanding when we should first treat people for HIV. And we had guidelines that generally recommended that we not initiate therapy until CD4 counts fell below different arbitrary thresholds. But eventually, in around 2013, depending on where you were in the world, the consensus swung to say we should treat everybody with HIV infection independent of the CD4 count. And you look back at this and say, is there any other treatable condition for which we say, let's wait till your disease is more advanced before we start you on treatment? Because I don't think we do that with other conditions. But that's really what we did in the history of HIV. And then in 2014, UNAIDS introduced this policy, or at least I shouldn't say policy, but this aspirational goal of the 90-90-90 plan, in which they wanted to have a situation by the year 2020 that 90% of people with HIV infection knew their status, at least 90% of them would be on antiretroviral therapy, and at least 90% of that group would have suppressed viral load. But together with this policy, they actually also said 10 years from 2020, we want to see the 95-95-95 targets met. So that was proposed in 2014. And then in 2016, two other major developments occurred. There was the formal birth of the U equals U movement, which I'll talk about in a little bit, the undetectable equal untransmittable concept. And then also in 2016, the World Health Organization endorsed Rapid Start, recommending that people with a new diagnosis of HIV infection should be started on antiretroviral therapy within 7 days of that diagnosis. So there's 38 years in one slide. So where are we at globally? Well, we have the statistics for the end of 2017 from WHO and UNAIDS. 77 million people have been affected cumulatively up to the end of 2017 by their estimates, and regrettably 35.4 million of those folks have died of HIV-related illnesses. At the end of 2017, there were about 37 million people living with HIV, and we need to acknowledge that 70% of them live in the continent of Africa, 70%, or about 26 million. And while we sometimes forget this in North America, where our epidemic is predominantly male, globally, 52% of adults living with HIV are women. And that's not, so we need to be mindful of that. 1.8 million were children under 15. There were 1.8 million new infections in 2017. The good news is that number is gradually going down, but it's still a lot of new infections. And there were nearly 1 million HIV-related deaths in 2017, a third of which were attributable to tuberculosis. With respect to antiretroviral therapy, 21.7 million were receiving that, and 17.3 million globally are estimated to have virologic suppression. So if you look at the 90-90-90 metrics for the globe at the end of the year 2017, this is what we see. UNAIDS estimates that 75% of people who have HIV infection are aware of their status. Of those, 79% are on treatment, and of those, 81% are virologically suppressed. So at the end of 2017, not one of the three metrics of 90 has been met globally. Not one. And in fact, that 47% of the world population with HIV is estimated to be suppressed at the end of 2017, which means that 53% are viremic. So let's come into Canada now and look at what we understand about our epidemic from the latest PHAC data, Public Health Agency of Canada. About 65,000 Canadians are believed to be infected with HIV. And to put it in perspective, we are not even 0.2% of the global burden of HIV disease in Canada. There were 2,402 new diagnoses in the year 2017. 75% in men, 25% in women. That ratio has been fairly steady in Canada over the last decade. And 83% are attributable to sex with a man, whether you're a woman or a man. And 16% attributable to injection drug use. But we have overrepresentation of two minority populations in Canada. So our Indigenous population constitutes approximately 5% of Canadian population, and they bear 20% of the burden of new diagnoses in 2017. And African, Caribbean, Black Canadians, according to the last census, were about 3.5% of the Canadian population, and 25% of new diagnoses in 2017 occurred in this population, although I will acknowledge quite a number of those actually were acquired in Africa and not in Canada. So our incidence rate in Canada in 2017 was 6.5 per 100,000, with rates 3 times as high as men as in women. Unfortunately, our new diagnoses in Canada have increased every year since 2014. okay? Increased every year since 2014 when the rate was 5.8 per 100,000. Our lowest incidents are in the Atlantic region, and our highest incidence is right here in the province of Saskatchewan, and I'll say a few words about that. So this data comes directly from Saskatchewan government HIV/AIDS reports. And these are rates per 100,000 of new diagnoses over the 10-year period from 2008 through 2017. And you can see the rates are consistently higher in Saskatchewan. And in the most recent year, it's about 2.5 times the rate that it is elsewhere in Canada. And the other thing that I think everybody's been aware of and has been re-emphasized in different parts of this meeting is that the epidemic in Saskatchewan heavily is disproportionately affecting Indigenous peoples. So you can see on this graph here the hash bars below representing the proportion of new diagnoses over this 10-year period in Indigenous people, and it's generally between 75 and 80% of all the diagnoses. So if you actually calculate the rate per 100,000 of new diagnoses, at least in the year 2017, non-Indigenous Saskatchewan residents have a rate of 3.8 per 100,000, which is below the national average, and Indigenous residents of the province of Saskatchewan have a rate of about 75 per 100,000, and this is a very serious public health situation, obviously. So where are we at with the cascade of care in Canada at the end of 2016? These are PHAC data. So with respect to the 90-90-90 metric, we've actually met the third metric in 2016 with 4 years to go. So that's not bad. We've done, you know, and hopefully we've made some improvements in the ensuing years, but we don't yet have the data. But if you look at the calculation, what everyone needs to understand is the 90-90-90, if that metric were met, that means that 73% of people would be suppressed, but still 27% would be viremic. So where we were at the end of 2016 is we had 63% suppressed, and therefore we had 37% viremic. So there's still a reservoir, at least at the end of 2016, of transmissible virus that we need to collectively improve upon. So we generally have a three-prong approach to dealing with HIV. We've got prevention, treatment, and cure, and I'm going to talk first about treatment, and it'll become apparent why later I'm going to pick that first. So up to the present time, there have been 30 individual antiretroviral drugs approved by Health Canada, 30, starting with AZT to the present. And the current treatment paradigm is a lifetime suppressive therapy. Most patients are now receiving a single tablet regimen. In fact, Health Canada has approved 10 such regimens, and the 11th regimen is under active Health Canada review right now. Most patients are also receiving an integrase inhibitor because this is the best tolerated class of drugs and reduces viral load the fastest. And antiviral resistance has now become a very infrequent phenomenon. Most clinics have legacy patients who were exposed to suboptimal therapies years ago and have archived resistance, but our more recently diagnosed patients, for the most part, have wild-type virus and very little resistance. And the good news is the life expectancy of people living with HIV continues to improve, and most of the recent estimates show that there is very little difference between the life expectancy of people living with HIV who are on antiretroviral therapy than the general population, with the exception of the subgroup injecting drugs. So virologic suppression rates continue to improve. These are US data from 1997 to 2015, and you can see they continue to increase independent of age, sex, ethnicity, or HIV transmission category, exceeding 90% in more recent years. The therapies are just getting better and better. And drug resistance, as I mentioned, has become fairly rare. This is just the abstract from the group from Switzerland, the Swiss HIV cohort, just saying how infrequently they are now seeing drug resistance. I would say the same is true in Canada. And we have some trends in antiretroviral use over time. So what we are seeing is that over time, back in 2012, there were about 11% of Canadians receiving a single tablet regimen. Now it's in excess of 60%, and that trend is going to continue to increase as some of the newer approved drugs get to public funding. We see an increase in integrase use and a compensatory decrease in the use of non-nucleoside reverse transcriptase inhibitors and protease inhibitors. We're seeing a decline in the use of older nucleoside analog reverse transcriptase inhibitors and an increase in the use of tenofovir alafenamide. And we are seeing some increased uptake in Rapid Start, which again is initiating people on therapy within 7 days of a diagnosis, rather than waiting to get every single lab test back first and delaying initiation of therapy and risking disengagement with care and more onward transmission in the interim. So one of the trends that is transitioning now in the field of HIV/AIDS is a look towards long-acting antiretroviral therapy. This is being looked at both in the context of treating established HIV infection, but also preventing it as PrEP. And in fact, 11 days ago, the first such regimen was filed with the United States FDA for consideration of approval. So we are moving in this direction as potential options. Now, the first generation products are expected to be products that have to be administered intramuscularly in the gluteal muscle by health professionals. So there will be some logistical issues with the institution of this, but there's research looking at alternative ways to deliver long-acting therapy, and these might include self-administered subcutaneous injections, subcutaneous implants, transdermal patches, or pills that have a phenomenally long half-life. So we will see developments in this field in both therapy and in PrEP. So the reason I talked about treatment first and now switching to prevention is treatment is prevention. And that is something that we've come to understand more recently than perhaps we should have. So we know that people living with HIV who are on suppressive antiretroviral therapy cannot transmit infection to other people. And that is the U equals U movement. And while it was hypothesized some time ago, it's been robustly tested in a randomized clinical trial called HPTN-052 and 3 very large cohort studies, Partner 2, and Opposites Attract. Partner 2 was just published recently and got some noise in the press, but it was presented last summer. And when you put these studies together, we have data with over 150,000 condomless sexual acts with absolutely no cases of linked HIV transmission. And this is true in both male-male couples and male-female couples. Very robust data that support this. We also know that suppressive therapy prevents mother-to-child transmission. And if a woman is on suppressive ART from the date of conception all the way through to delivery, there is no documented transmission. There are some occasional transmissions if a woman is started on treatment later on in pregnancy, but even there the rates are generally 0.5% or they're very, very low. So that's been a tremendous progress. So Tony Fauci and colleagues at the NIH wrote this almost like an op-ed in the JAMA in January. The science is clear: with HIV, undetectable equals untransmittable. And this has been very empowering for many people, and it's based on really solid science. So other prevention tools. So we have quite a number of things in our prevention toolbox, and I'll start listing those first that have been validated in classic randomized clinical trials, almost always with a placebo control. So PrEP is one, and there have been multiple clinical trials attesting to the efficacy of PrEP. Treatment as prevention, I already mentioned HPTN-052. I mentioned ART as prevention of mother-to-child transmission. That was first shown in a randomized trial using AZT monotherapy. We have 3 randomized trials showing that male circumcision has about 60% reduction in HIV incidence in the men. We have 1 randomized trial showing that cesarean delivery reduces transmission by about 50%. Of course, now with our understanding of potent antiretroviral therapy, cesarean delivery is only recommended for non-obstetrical reasons when viral loads are over 1,000. And then we have 2 randomized trials looking at the dapivirine vaginal ring that were done in Africa that had efficacy, although the efficacy was not as great as we were all hoping for. So these are randomized preventative measures that have been validated in randomized clinical trials. We have other preventative measures for which we have other evidence other than RCTs for. So that includes screening of blood products and tissue products before they're used for human use. Condoms in the Cochrane analysis are estimated to have 80% efficacy. I mean, it's 100%. You do experiments in the lab. HIV doesn't penetrate an intact latex condoms, but in the real world, there is some condom failure, and that's why the estimate is 80%. But an important reminder is that condoms prevent all STIs, not just HIV. And then, of course, we have post-exposure prophylaxis following sexual and occupational exposures, and we have needle and syringe exchanges for injection drug users. So all of these are effective preventative measures. So PrEP was first demonstrated in 2010, but regrettably, the uptake of PrEP has been very slow, and there are many countries in the world today where there is no public funding for PrEP. It is improving, but it's a problem. So many studies have validated the efficacy, and almost all the failures of PrEP can be attributed to poor adherence to therapy. And Canada was relatively slow taking up PrEP at the public expense, to be very fair, with the exception of Quebec, which was certainly in first. But in 2018, the majority of the provinces are finally funding PrEP, and we need to get our uptake going. And we have good evidence that when there's a high uptake of PrEP at the community level, we see benefits even in people who are not taking PrEP because of almost like a herd immunity effect from many people at risk taking the therapy. So if you're interested in PrEP, I'd encourage you to go to prepwatch.org. Lots of data globally about what's happening there. So our friends at the LGBT Center in Los Angeles embarked on a really courageous campaign a couple of years ago to try and encourage the uptake of PrEP. So this is a billboard in West Hollywood. If you were down there, you may have seen it. And in the bottom left, by the way, they still talk about condoms. So PrEP's important, but so are condoms. And they actually secured a website called prephere.org that you can see on the bottom right of the slide. And what they did with this campaign, within 3 months, they had 25,000 page views, 17,000 click-throughs to the risk assessment score, and the uptake of PrEP in Los Angeles tripled with this campaign. So you can be wussy, as we tend to do in Canada, and get small uptake, or you can be bold and courageous, and then you'll get much better uptake, as they did. So while we're talking about California, a little bit north of Los Angeles, there's this town called San Francisco, and they have this program called Getting to Zero San Francisco, and their website is gettingtozerosf.org. I'd encourage you to surf that website too, because they have some really innovative plans that are dealing with high uptake of PrEP, rapid start, and retention in care. And with that, they've been able to show a 51% reduction in new cases of HIV infection in the city of San Francisco from 2012 to 2016. And I was on their website earlier this week, and their 2017 data are in another 5% reduction in 2017 in the city of San Francisco. Okay. So we've also shown, the folks in Australia did this study the state of New South Wales is the biggest, most populated state in Australia. It contains the city of Sydney and has 8 million people in the whole province. So they did a rollout with 3,700 high-risk MSM who met criteria for PrEP. They were started on PrEP in 2016. And then over 4,100 patient years, only 2 individuals prescribed PrEP failed, meaning they developed HIV infection. But they were documented to be poorly adherent with PrEP, which is the usual story when PrEP fails, with some rare exceptions. But the interesting thing is they showed a 25% reduction in new diagnoses of HIV among MSM in the entire state of New South Wales with these 3,700 high risk. Because the pool of at-risk MSM was reduced by having 3,700 of them taking PrEP. So there's a community effect if you have big uptake of PrEP in a high-risk population. So the biggest missing link we have with respect to HIV prevention, let's be clear about it, is we do not have a preventative vaccine. Although there is research going on, it isn't obviously close to fruition yet, but we really need it. We have no precedent for elimination of an infectious disease without a highly effective preventative vaccine. What about HIV cure? Well, this is a hard nut to crack for sure because there actually are 0 cases of natural cure documented. But I think everybody's aware of 2 cases that were cured through bone marrow transplant. So very briefly, these 2 individuals had a hematologic cancer. They needed a bone marrow transplant because of their blood cancer, not because they were HIV positive. but they happened to get donors who were homozygous for the Delta 32 mutation, which means they lack the co-receptor on CCR5 to allow HIV entry in the cell. So we have 2 people in the world who were cured through this unique set of circumstances, but who have to take anti-rejection drugs for their bone marrow transplant. So they're actually at higher risk for opportunistic infection from the drugs than they would have been from suppressed HIV. And what you may not know is there were 6 other HIV positive patients who've had the same bone marrow transplant who unfortunately didn't survive. So this is not a tool that can be wide-scaled uptake for prevention, for cure. We need other tools. And some of the things that are being looked at is we have some broadly neutralizing antibodies now, one of which was published recently in the New England Journal of Medicine. There's studies looking at gene therapy. Can we target the CCR5 co-receptor and alter it so that the virus can't get in without taking a bone marrow transplant from somebody else to do that? So these are some of the strategies that we're looking. We're looking at latency reversing agents that try and get the virus out of the latent reservoirs in the body, which are numerous, and a bunch of immunomodulatory agents. So the current thinking is that, yeah, we're still going to need antiretroviral drugs, but maybe we can use these various immune strategies to try and get the virus out of all of its latent reservoirs and get rid of it with host immunity. So we shall see how that transpires. I do want to spend 1 minute recognizing, telling you all this as success stories. We made a bunch of fumbles along the way in HIV/AIDS, and I want to acknowledge some of them. So we did antiretroviral drug holidays, and that turned out to be a bad idea. For those who know the SMART study, that's why I said it turned out not to be very smart. We delayed antiretroviral therapy till CD4 counts fell below thresholds. That also didn't prove to be the right thing to do. We waited till somebody was completely treated for their opportunistic infection before starting antiretroviral therapy. Randomized trials have shown that is not the right strategy. We used dual nukes that caused lactic acidosis and some deaths. We used hydroxyurea. We gave 5, 6, 7 drugs to some people. We did a lot of things that turned out not to be the right thing. And I would say, I'll just focus on the last one. When our colleagues in Switzerland put out a statement in 2008 saying that people suppressed on antiretrovirals don't transmit HIV, all the establishment of HIV in the world, including the WHO, including the CDC, including the NIH, say, no, we're too early to say that. We don't have the data to support that. 8 years later, everybody's in. So I'll give Swiss the credit. They were right all along. So in the near future, what do we have to do? We have to improve everything on the cascade of care in HIV. And you can debate how many bars there are on the cascade. There's certainly more than what the WHO says. Because yes, you have to diagnose people. They have to be linked to care. They have to start on antiretroviral therapy. They have to get suppressed. But the thing is, they have to stay suppressed. It's not a one-off. It's not a target you hit once and say, okay, good, we're done. You have to do this over a lifetime. And that can be a challenge because life happens. So a person can get virologically suppressed, but then intercurrent things happen in their lives that may make it hard for them to stay on therapy over the long haul. So this is a bit of a challenge that we have. And as I mentioned before, we have inequities. I mentioned the specific situations in Canada with our Indigenous peoples and the ACB population being heavily overrepresented in the Canadian epidemic. The Americans have a similar situation. In the US in 2017, blacks accounted for 13% of the US population, and yet they had 43% of the new diagnoses of HIV infection in 2017. We also have inequities in Europe too. And the opiate epidemic is definitely a driver in some communities more than it is in another. And as I mentioned, in Europe, there's a huge difference between Eastern Europe and Western Europe with respect to how the epidemic is playing out and the ability of resources in Eastern Europe where PrEP is almost not available at all. So I've said to you before that I don't think we can completely control the epidemic without a vaccine. I remind you that the 2020 target of 90 means that there's 73% suppressed. If you do the math on the 2030 target of 95, that's better. It's 86% suppressed, but it still leaves 5.5 million people with viremia. So we have a way to go to get complete control of the epidemic at a global level. Interestingly, the Americans, it was a surprise announcement to many of us that they announced, but a good announcement, that in late February they announced this plan where they're trying to end the U.S. epidemic, and their definition of that is a 75% reduction in new HIV diagnoses in 5 years and a 90% reduction in 10 years. And this is going to be a combination of test and treat, high PrEP uptake, and engagement in care. And the map on the right shows that they understand in the U.S., just as to a certain extent we have the same thing in Canada, there are focal hotspots in the U.S. The U.S. epidemic is not equal across the whole country. For the most part, there's low incidence in the Midwest, for example, and very high incidence in certain spots. So the U.S. is going to concentrate their resources in the so-called hotspots. And I do wish them well, because they need it. So I'm going to conclude my presentation in 2 slides here. Huge progress has been made in the field of HIV/AIDS in the 38 years since the CDC reported the existence of this entity. 30 individual antiretroviral drugs have been approved by Health Canada and 10 single-tablet regimens. Modern ART is highly effective, very well tolerated, high genetic barrier to resistance, and low discontinuation rates. Suppressive antiretroviral therapy prevents HIV transmission, U equals U. The life expectancy of people living with HIV is similar to the general population if they're taking antiretroviral therapy, and ART uptake globally is increasing, and especially in Africa, where 70% of people living with HIV are. So we have multiple highly effective HIV preventive strategies. We've nearly completely eliminated mother-to-child transmission in high and middle-income countries. And we know that high uptake rates of PrEP in high-risk individuals can have a population effect on their local community. But the current tools that we have, even if we don't in the short term have a cure or a preventative vaccine, we really need to step up with the current tools, because the current tools are pretty darn good. So we have to get more people diagnosed, treated who are positive, and more people at high risk on PrEP than we are currently doing. And so yes, we still need a preventative vaccine and curative therapy, but we've come a very long way. And I'll thank you for your attention, and I will introduce our second speaker momentarily. Thank you. So we're going to hear now from Dr. Mark Anton, who lives right here in Saskatoon. He works at the Westside Community Clinic and at the Opiate-Assisted Therapy Program for Saskatchewan Health Authority. He's a full-service family physician with a special interest in addictions, HIV, and hepatitis C. Dr. Mark Anton is the co-founder and board chair of Sanctum Care Group, which provides transitional housing and care to those living with HIV, and a transitional care home for pregnant women living at risk. Dr. Mark Anton will be presenting a case study of Sanctum with a strategic focus on improving social determinants of health. Dr. Mark Anton.
Thank you. My conflict of interest slide. What is Sanctum? It actually, in 2013, Caitlin, our executive director, which I think she just stepped out to another meeting, and oh no, there she is, I see her. There she is, wave to everybody, Caitlin. We went out for lunch, and we went out and over a noodle bowl, but actually we each had our own noodle bowl. This isn't some 101 Dalmatian weird kind of story kind of thing, but we each had our own. The only reason I was there is because I had to pay for lunch, but it was not a great day. That week we had a woman who had been in hospital but had left AMA. Went home to a home that was not fit for any human being to be staying at. And we knew she was sick, but we couldn't convince her to come back to hospital. Her partner phoned outreach and said, she's not doing well. We called the ambulance. She was brought into the ER, and 6 hours later, she was dead. She died of end-stage AIDS at a time when it shouldn't have happened. And we thought, why is this happening? And so Caitlin had a great idea that we need to do something different. And so Sanctum is an NGO, or it's a charity made up of interagency professionals working directly with this population. So social work, addictions, mental health issues, homelessness and poverty. I'm assuming you guys are all literate, so you can read the slides. We have a mission and a vision. We do our best to treat people with dignity and respect. Since we've opened Sanctum, we've had 9 or 10 patients come in through our doors to palliate. Some were palliative for end-stage AIDS, but others had other illnesses, end-stage COPD or cancer. But our very first palliative patient, Victoria, a wonderful crotchety 40-some-year-old woman who she came into Sanctum, and I really thought we could save her. Yes, she had AIDS. Yes, her CD4 count was 20, but we have good drugs, and we can save her. And so every 2 weeks, I would go into, and I'm sorry, some of you from Saskatoon have heard this story a lot of times, and as I get older, I'm sorry I'm going to be repeating myself like an old person. But Victoria, I would go in every 2 weeks and say, I think we should try some meds. And she would look at me, and because I outweighed her and she was only 75 pounds and she couldn't really do much, she would say yes. But the minute I went out the front door, she would tell Kathy, our nurse, I'm not taking Mark Anton's goddamn meds. And so Kathy would tell me the next day, oh my God. So I try again 2 weeks later, and I try again 2 weeks later. Finally, I'm a bit slow, so finally one day I went into Victoria's room and I knelt at her bed and I said, Victoria, what would you like? And she said, I do not want to take any more of your pills. She was tired, she was sick, she was tired of suffering. She had been on numerous regimens before that all made her sick, and she just did not even want to try anymore. And so I said, okay, I said, that's fine. I said, we'll do what you want, and we will help you get comfortable, and if you ever, and then of course I had to put in there, because as a physician, if you ever change your mind, we're happy to restart. 3 weeks later, Victoria died of end-stage AIDS, with Kathy, our nurse, and Caitlin, our executive director, at her bedside, no family. But she died with dignity, and she died with respect. And she died teaching us a lot about what we're doing. Victoria still comes to visit us on occasion. A couple of months ago, we have a gate in the front yard at Sanctum, and as I was leaving from doing rounds there, the gate suddenly slammed shut right in front of me, and I'm pretty sure she was trying to trip me up. Victoria was a tough lady and a beautiful person, but we have lots of Victorias here in Saskatoon, and that's why we have Sanctum. Substance use disorder is just like any other disease, and we have an obligation to help our patients manage it. Sanctum, although it's in the center of that circle, all those other organizations work with us to provide care to this population. What's beautiful about Sanctum is we just have to provide the home and a place for someone to stay, and all those organizations with their budgets can come and help us do our thing. We didn't have to reinvent the wheel, we just had to provide a spot for people to come. We know, the stats were shared with us by Dr. Shafran, but we have a high incidence of HIV. Our epidemic is driven by over 79% of IV drug use. We have multiple stigmas with our patients. They have HIV, they have Hep C. Even though we can cure Hep C, it's still a huge stigma. We have poverty, we have racial stigma. There's lots of homelessness in Saskatoon, unfortunately, and a high incidence of mental illness. Crystal meth, we've seen in our opiate population in the last 3 years a 70% increase in crystal meth use. We have a long legacy of adverse childhood experiences. This is not as simple as writing a prescription for one pill once a day and saying, hey, you can live a normal lifespan, thank you very much. We had a patient last fall in hospital with end-stage AIDS, and we were trying to transition him to Sanctum because the hospital's not the funnest place to stay, especially if you're not well, I guess. And we had him all teed up, ready to come over, and the last second he said, I can't come. I said, well, we think we're offering a very beautiful home. And his partner had said, if you go to Sanctum, then don't ever come home again. And we thought, wow, what's that about? our first reaction is, she's obviously not a very nice person. But that wasn't it. So someone on the team actually sat down with her and she said, if he doesn't come home the day after I have money to buy groceries and put them in the fridge, the extended family comes in, eats all the food, and she has nothing to feed her 3 kids for the rest of the month. So we have a magic pill that can help you live to the normal lifespan of 75 or 80. But this patient could not even think about next week because he had to worry about providing for his family tomorrow. And that's the social determinants of health. If we do not ask our patients, or we talk about health literacy, how many of our patients don't have health literacy. Many of us as healthcare providers have 0 street literacy and 0 trench literacy. And it is our job to say, not what is the matter with you, but what happened or how did you get here? And that's what the social determinants of health are all about. We have a high incidence here of other illnesses affecting our IV drug population, such as osteomyelitis, endocarditis, and septic arthritis. All of those require 6 weeks of IV vancomycin or other antibiotics. If you and I went to the hospital today because we were working on our deck at home and stepped on a nail and happened to get an infection in our foot, we would last in the hospital 3 days. And we would tell the doctor, said, I'm out of here, what are you going to do about it? And they would arrange home care. They would arrange IV antibiotics for us to go at home, or we could come back to the hospital twice a day to get our antibiotics. This population, if they don't have a home, God forbid we send someone home with a PICC line because we know they're just going to fill it full of drugs. So we don't allow our patients with substance use disorder to go home with a PICC line, so they have to stay in the hospital for 6 weeks. When was the last time someone the age of 30, who after 7 days of antibiotics starts to feel a little bit better, is going to lay in a bed, listen to the rules, next to a 90-year-old person with dementia who's in the hospital for other reasons? It's not going to happen. We got to quit pounding square pegs into round holes and expect better outcomes. So at Sanctum, what we do is if we find out someone's in hospital and they're going to be there for a long stay, as soon as they're feeling better, day 7 or 10, we interact with them and say, hey, would you like to come to Sanctum? You can come here and you can finish your antibiotics. We have home care, but if you don't have a home, it doesn't make sense. And it's about education. When I first started at Westside Clinic 10 years ago, we had a day of homelessness where we were asking the public to donate stuff for our homeless population. And so someone phoned and asked where they could drop off a couch. I'm not sure where a homeless person puts a couch, but that's the reality. And so we have to do a better job at educating our public. So unfortunately, we have lack of resources in our acute care facilities to deal with mental health addictions. The staff is there for acute care. If you need acute health care, a hospital is a great place to be. But if you're subacute and you have dealing with mental illness, addictions, or other issues, it's maybe not the best place. There's lack of education and resources to manage patients in acute withdrawal. It's getting better, but we have a long ways to go. Of course, there are lots of areas in Saskatoon that maybe home care, it's not safe to go, and we understand that. Everyone should be safe at their job. And so, but how do we improve that? Instead of saying, we're not going to go to that entire area, what do we do to make that different? We have a lack of palliative care beds in Saskatoon, and we have never had someone with HIV make it to the palliative care ward. It's because it's full, and we won't, probably. And our patients leave. Someone tells them, well, you know what? You missed your antibiotic. Well, I'm only an hour late. Well, too bad. You did this to yourself. Why are you here? You don't want your treatment. Why are you even here? Those things do get said to our population. And everyone has a bad day at work. We get that. But we need to really listen and help figure this out. We have patients that they stay away from hospital till the last second, and then it's too late. And they die in our ERs or in the ICU. So we had a 27-year-old patient with HIV/AIDS, CD4 count at 21. Sadly enough, he'd injected enough Ritalin and Talwin that he had developed talc lung. His lungs were not great. He was on home oxygen. And he would get exacerbations. He'd get infections, or he'd get pneumonias, or he would just get ill. And he'd go to hospital, and he'd be intubated. And within minutes of them extubating him, he would walk out of the hospital. And he wouldn't walk out with his oxygen, and he'd be gone. And we did this numerous times. We'd start him on methadone. He would stabilize for a week or two, but family was important, and his family didn't live in Saskatoon, so all of a sudden he'd be gone. So he's not on it, and we'd get a call from God knows where. We have so-and-so in hospital here. What meds is he on? Well, he actually hasn't been on any because we haven't been able to stabilize him. We opened Sanctum, and he was one of the first few that we had. He stayed for 3 months, never left. This is a guy who'd never stayed in hospital for any length of time or anywhere else. That was years ago, 4 or 5 years ago. He's now not living in Saskatoon. He's with his partner. They have all 4 of their children in their care. His CDVR counts are actually normal, and he has a healthy weight. And this is someone we really did not think we would help. And he felt that this was the first time someone actually cared about him as a human being. I have another patient who CD4 count was 30. She'd been off methadone for 8 times. I'd restarted her 8 times. You wonder why. Like why didn't I stop after the second? Because we knew it wasn't going to happen. But using opiates and crystal meth. She finally engaged, and I did a chart review, and she had, in the year previous to her starting on methadone that 8th time where she stabilized, 25 visits to our clinic. That was years ago. She's now non-detectable, has 5 of her kids in her care. She's a single parent. We've treated her Hep C and cured it, and she has stable housing, and she's working. And I asked her one day, I said, why did you keep coming back? Because, I mean, you could tell I was frustrated with her, and she said, I knew you guys cared about me, and it was a safe place to come. That's all it took. It wasn't that we were feeding her hydromorphone or IV heroin. It's just that she knew that she could come to us and that we actually cared, even if she wasn't ready. If we treat human beings like human beings, if we give them a roof over their head, if we give them food to eat, they get better. When we were trying to pitch Sanctum to the powers that be, I would often say that people with HIV/AIDS are like our NICU babies. If we feed them, keep them warm, they will grow. And I think that's what we like to say we do at Sanctum. We know the research says that if you have HIV and you're homeless without support, your life expectancy is 5 years. That's the real world data. We found that we only have 10 beds at Sanctum, and those 10 beds are often full, and we have a wait list, and so what else could we do? We were still losing people, AMA or patient-initiated discharge, whatever politically correct term you want to use. But we developed our HEART team, our HIV/AIDS response team, thanks to a generous initial grant from Gilead, and now after a year of having it on the ground, our metrics have allowed us to prove to the health authority to fully fund our team, and so we're very happy and grateful for Gilead for that. But our model of care was to bring the social determinants of health together with our medical team. Our team bridges the gaps between acute care and community. So the goal is if someone known to us with HIV is admitted to the ER or the hospital, and if the patient consents, the HEART team is called, and we go and we interact not only with the patient, but we also interact with the team in the hospital. So if the ward really doesn't understand our patient, we kind of help soften. And we've made big strides with this. So at Sanctum, we connect patients with primary care. We connect them with specialist care, whether that's infectious disease or psychiatry or obs-gynae. We connect them with addiction services if they want. We get them on opiate-assisted therapy. We provide access to stable housing. In the first year, we housed 90. We had a 97% of our clients were housed after they had left Sanctum. One person didn't want to. We make sure they're on their highest level of income support, and we connect them to the many outreach services that are out there. I encourage you, if you have time, to check out our website at sanctumcaregroup.com. We have a couple of videos on there that are much better than listening to my monotone voice. This graph is to show that if you put someone in a home where they can store their meds, they'll actually take their meds and their viral load will become undetectable. If you leave them on the street, their viral load will go up. So it's important to focus on all things that keep us safe and make us human. The basic necessities of life equal life. If we don't have them, we don't have. When one loses hope, one has nothing, and it is our job to provide care, compassion, and humanity to a population that somehow has fallen through the cracks. And HIV care is so much more than one pill once a day. Thank you.
Thanks very much, Morris. I'm going to introduce now Dr. David Tu. He's a family physician, community-based researcher, and UBC clinical assistant professor with a focus on Indigenous peoples' health, HIV, hepatitis C, and substance use disorder. His family practice has been centered in Vancouver's downtown Eastside for the past 18 years. He worked at the Vancouver Native Health Clinic for 17 years and currently works at the Urban Indigenous Health and Healing Cooperative and the Luma Medical Center. He has worked previously with the VCH Stop HIV/AIDS program and was a longstanding clinical associate on the St. Paul's Hospital HIV ward in Vancouver. He's a preceptor for UBC Aboriginal Family Practice Residency Stream, and he lives in Vancouver with his wife and 2 children. He'll be presenting a case study of his practice model and how the clinic has integrated Indigenous traditions and social constructs to improve patient outcomes, retention, and linkage to care. Dr. Tu.
Well, thank you, Stephen, for that great introduction. Thank you to the conference organizers. What a wonderful conference. It's like such a great energy here. And to those organizing the symposium, and acknowledgements to the members of Treaty 6 and to the members of the Métis Nation. It is my pleasure to be here to present sort of the evolution of the team of practice that I've been working with over these last decade and a half. And we're going to just talk about some of the strategies that we've come up with in Vancouver's downtown east side. Those are my disclosures. And can't get away from these learning objectives. But what I'm hoping is to describe to you all the evolution of what we're now calling the Kilala Lalum, which is a Helcom Lalum term for butterfly longhouse. Helcom Lalum is the language of the Coast Salish people where we're working, and how we're trying to develop this model for the care of Indigenous people living with HIV. And I'm hoping that you'll maybe come away with some understanding of how to further promote health equity and wellness for the people that you see using some of the models that we've explored over the years, that being the chronic care model, the Vancouver Indigenous Elders Partnership, and the patient medical home models of care. So I'm really here to tell a story, and the setting of the story is Vancouver's downtown east side, which is a village of about 17,000 people nestled within a larger city of about 1 million people. And it's a little village of immense diversity. People from all over Canada, all over Turtle Island make their home in this community, and about 25% of the people living there identify themselves as Indigenous. I took my first real job in 2005 as the clinical coordinator for the Vancouver Native Health Clinic. And at that time, there was a very high prevalence of HIV in this neighborhood, and it was twice as high for Indigenous people compared to non-Indigenous people. And the incidence of HIV was also twice as high compared to non-Indigenous people. And there was this incredible mortality rate that we were experiencing in the neighborhood. The 3 years prior to taking this job, I had been working with Doctors Without Borders in East Africa, mostly in the Democratic Republic of Congo. And over those 3 years, developing an HIV program in a conflict zone. And part of that was, monitoring the mortality in that program. And we got to a mortality of around 8% per year, which took a lot of work to get there. The contents of coming back to Canada and working the downtown east side was that for the rest of the non-Indigenous HIV positive community, there was a huge reduction in mortality. But this was not being experienced by Indigenous people. And so one of the first things that we did over those first 3 years that I was in this coordinator role was just start counting the crude mortality. And I was seeing 12%, 9%. In the first year I was there, we have an annual burning ceremony, and we placed 50 plates out during that ceremony. And that worked out to basically a death a week in that prior year. So, with all the resources in Canada, it seemed crazy to me that we couldn't do better. And so we organized ourselves along with a really strong group of members from the community, and we started a participatory research and quality improvement project, and we called it Chinup. So the Complete HIV Care for Native Urban Peoples program. And then we sort of ran this program for 3 years, and what the intention was to see if we could use this chronic care model, which had been used in other disease models, and try to shift away from infectious disease to a sort of chronic care paradigm. But what we began with was actually just asking people what they wanted. And there was a lot of qualitative input and stories. And people wanted very different things from what clinicians were interested in. And it was a much more holistic picture of what people desired to change in their lives. And so we tried to find common ground with members of the community's aspirations for their own health. And we said, well, how can we work with this kind of rigid model that worked for diabetes, smoking cessation, congestive heart failure, and adapt it to our needs? So we started working on it and input. And one of the first things we did is realize that one of the outcomes, which is sort of shown at the bottom of this model, it needs to include some of the determinants of health, and that's sort of trying to honor those goals that community members were identifying. And that we knew that we need to really emphasize the importance of having trusting relationships. Relationships are always important in healthcare, and having informed, motivated patients on the one hand and a proactive team on the other is great, but if you don't have trust, it all falls apart. And what we wound up doing was adding an extra layer to the healthcare system. And in that extra layer, we sort of created a bit of a basket of support. We still had, to provide effective care to a population, you need a good information system. You need to support your care providers with the best tools. We wanted a one-stop shop where we had counseling, social work, physicians, outreach workers, peers, all working together, and a good self-management program, which we invested in heavily. But we also know that we needed an intensive case management system, and we needed to be flexible and individualized in our care practice as sort of a basket to catch people as they were slipping through the system, be able to lift them back up. From this, through also building sort of community involvement and trying to address public policy, we showed over a 3-year period that we could make significant improvements in some of the outcomes that were sort of important to the powers that be, things like screening rates, vaccination rates, being on antiretrovirals, being virologically suppressed on antiretrovirals. And we did this, again, with our partner, with our sister clinic in Prince George. Through that system, and we continued to kind of monitor mortality, and we could see how we began in 2007 with quite a large gap in mortality between Indigenous and non-Indigenous people. We showed that we were able to close that gap. And that was published in Canadian Family Physician now a long time ago. So now I'm going to tell you a story about Burt, which is not his real name, but Burt and his family. So Burt is from North Battleford, Saskatchewan, and he gave me permission to share his story with you here today. He's from the Métis Nation. He at that time was 53 years old, father of 4, divorced, university educated, but was street involved from the age of 15 onwards and independent since then. So Burt showed up in the Vancouver's downtown Eastside in 2011, and he was just basically frantically searching for his daughter, who had recently become HIV infected, fled Saskatchewan, and was struggling with opiate addiction. Burt himself had been HIV positive since 2003. His CD4 at that time was 100, and he'd been on and off antiretroviral since 2008. Really a complex social history involving lots of physical violence as well as sexual violence, and carried with him a diagnosis of post-traumatic stress disorder, chronic back pain from previous episodes of osteomyelitis, severe opiate and stimulant disorder, and an HIV infection, Hep C infection. and arriving in the downtown Eastside, homeless, jobless, and with no connections to speak of. So, the system I described was able to actually sort of wrap around Burt. He was hospitalized not long after he arrived to Vancouver with HIV encephalopathy, esophageal stress, and quite a severe pneumonia. That intensive case management team engaged with him, and he did gain a lot of mastery and control over his use of opiates and stimulants. Was able to meaningfully engage in antiretroviral therapy. CD4 count raised so that he was it became above 200 and out of the risk of some of what had led him to hospital earlier. Maximized his income benefits and actually wound up with very appropriate housing for someone of his age. During the next sort of 4 years, it was a lot of primary care, treating his hypertension, his COPD, addressing his Hep C, lots of on-again, off-again issues around HIV and treatment of depression. He brought his 3 children in to have me be their family doctor, as well as his son-in-law. And for me, that was probably the strongest signal that I'd won his trust, that he was bringing his family forward. I went through and looked at his chart in 2016, still really struggling with what he'd say was poor health, lots of emotional distress, lots of family dysfunction that would kind of destabilize his world. So basically what Burt said to me, I'm not well. And wellness is a complicated subject. It's probably more complicated than understanding the pathophysiology of HIV. This is a diagram from the First Nations Health Authority in British Columbia, who put a lot of energies into kind of coming up with a conceptual model of what wellness means. And they established that there's a core of wellness that hangs on the individual, which kind of hinges on a balance between their physical, emotional, mental, and spiritual health. That there are aspects of wellness that involve responsibility, relationships, respect, and wisdom. There are the components that mean relating to your family, your land, your nations, your community. And then there are the context in which you exist, your wellness exists, the environment, the society, the economic, and the cultural background. So there's work to be done for Burt and his family on all of those fronts. And this is not new. This is a quote from over 150 years ago from a chief who survived the Trail of Tears and died in a prison reserve in Oklahoma, who recognized that wellness reinforces and is reinforced by sense of cultural identity. And there is actually quite a lot of literature around the importance of cultural continuity, cultural identity, in supporting positive health behaviors, especially around suicidality. They actually, there's a beautiful study in British Columbia where they looked at communities that had sort of on a scale, the rating of their sort of, how positive they felt about their cultural identity. And those with strong cultural identity had far below average rates of youth suicide, and those that had the converse had far increased rates of youth suicide. And there was a humility aspect to being I'm a non-Indigenous physician working in this field, and I recognize I have nothing to offer to improve someone's sense of their cultural identity, who they are as a person. I don't even know where to begin in that work. But I was very blessed in 2014 to have a team of elders come and agree to work alongside us. That's Elder Roberta Price, Elder Bruce Robinson, Elder Mar DeVault, Elder Bonnie Hanous, and Elder Eugene Harry, all of whom agreed to work with our team of primary care providers. Often, I'm not used to giving this talk without an elder standing beside me, so I'm actually going to read what an elder means and not feel so self-conscious about it. Elders are recognized by the communities for their leadership and accumulated wisdom, compassion, community devotion, and dedication to personal healing. From a Lancet article, elders are described as viewing mental illness in spiritual and social terms, as rooted in disconnection from families, traditions, communities, the land, and from oneself and spirit, and healing as requiring the reestablishment of these connections. So from 2014 to 2017 we got CAHR grants, community grants, we cared for about 500 individuals together as a team. And over time, we evolved this model where we sort of imagined sort of a primary healthcare team, a mental health team, and a team of elders, all sort of joining hands around an individual, and each doing our own work to address their physical, cognitive, emotional, and spiritual needs. And to do this, we know we needed to have sort of a shared understanding of goals, which really is like the goals are really whatever the patient wants. Shared respect for one another, being able to communicate both on the clinical EMR, but through meetings and informal gatherings, and an understanding of what each other does. And I've had I'm still part of that education, but I've learned so much about the sophistication of how different elders work, what they bring, what the different talents are. It's as or more complicated than the health system that I was trained in as a family doctor. We did a cohort study looking at 45 individuals who had their sort of hadn't had any previous contact with an elder within their primary care system, and we showed that rates of depression were using a PHQ-9 score were significantly reduced, and those reductions sustained over a 6-month period, and that's both clinically and statistically significant. And we showed the same change with respect to suicide risk. From an health economics perspective, we saw that comparing the 12 months before to 12 months after, there was a more than 50% reduction in mental health crisis that led to an emergency room visit. So, and probably more importantly, we gathered 39 stories from this cohort group and analyzed those stories together. This is a publication in CMAJ from last year if you want to get more details. But the themes really came out that through connecting with an elder, it created an opportunity to find a place of healing after prolonged periods of seeking and desperation, the opportunity to strengthen cultural identity and belongingness, develop trust and opening up, and that trust extended beyond the elders that we're working with. It really made a big impact to those of us providing primary care in this environment. A mechanism to cope with losses, and the opportunity to engage in ceremony and spiritual dimensions of care, which really was a resource for people to regain a sense of hope. So just returning to Burt and his family, Burt began connecting about 7-8 months ago now with an elder most weeks. He now can access sage and sweetgrass, and has started his own. He returned to what he used to do as a child, which was to smudge on a regular basis. Next week, actually, we're having his first sort of family circle, which is sort of a male and a female elder are bringing his family together to actually talk about some of the very difficult, traumatic things that happened when they were growing up. And I see it in him now, that there is a sense of hope that wasn't there a couple of years ago before those elders and that services kind of entered into his world. So if I think conceptually about what we've done, we started with a primary care clinics are represented in black here that was sort of anchored towards providing comprehensive care. A lot of same values as what you're hearing from Westside Clinic here in Saskatoon, targeting Indigenous people and trying to do the best we can. And I think what we did over those 3 years is we made space. We made financial resources, we made physical space, intellectual space available to a team of elders to come in and work with us. And we were looking after about 10% of the people that came in through this sort of partnership model. When we brought these stories back to the individuals that were part of this research, they said, oh, yeah, great, no, this was really good, you need to do way more. You can't stop with what you've done. They wanted really a system that would be culture first and primary care sort of second. And we had to sit with that for a long time. And it's like, well, how do we do that? Like, we got no funding, we got no resources. Trying to layer this new system onto an existing system we had experienced just really doesn't work. So we were compelled really by the voices of those community members to start our own nonprofit cooperative. So it's one of the few health cooperatives in British Columbia, and it's led by that same team of elders. They now form the board of directors, along with a few of us that have been brought along for the ride. And what we've done is, well, we took another model. That's the province of British Columbia has endorsed the patient medical home model developed in Washington State and evolved. And so we said, okay, well, how do we embrace this model? One is we knew we had to put culture in the center of everything that we do, and that we need to involve a network of elders within the circle of care providers that's providing the services, and bringing those same concepts of shared goals, respect, communication, and understanding. And we've iterated this a number of times, and we opened our clinic in October of last year out of some temporary sites, and managed to raise over $1.4 million to renovate a new space, and again, piecemealing funding together. We've got an operating budget sort of approaching $2 million now to expand and really try to fulfill this dream. And this is what our model looks like now, and that's the Kilala Leilum model of service. And really, it has a vision of really trying to promote equity and wellness for Indigenous people living in the downtown Eastside community. And the mission of how we're going to do this is to fundamentally provide culturally safe care in the broadest sense of what cultural safety means, and enact the recommendations of the Truth and Reconciliation Commission number 1923, which refer to health. Our values that we're embracing together are those of lateral kindness, respectful relationships, Indigenous ways of knowing, and being member-driven or patient-centered. Our strategies is to keep the elders leading the process, have responsible governance, be a very team-paced service, attain financial stability, hopefully, and continuously move towards quality improvement. And we'll keep on looking at other models, what things look successful, and remain a center for teaching and research. And so, just in closing, the evolution of this model took 14 years, and it took a strong participation from the community. It took research to validate, and was the kind of the mechanism for getting funding, and it regarded it needed a partnership with elders, and elders to be part of the decision-making process. And I think through assertive modification and adaptation of promising models, such as the chronic care model, our Indigenous Elders Partnership model, embracing cultural safety in a patient-centered medical home, I think you can make steps towards achieving some of what Stephen was talking about to have those outcomes be realized. And this is nuts and bolts, bit by bit work. But I just want to thank you all for listening to this. HIVAIDS.